welcome you on board on behalf of Genix Pharma. I really appreciate all of your efforts that in such busy schedule you have taken your precious time to serve for the humanity. And this is completely non-interest and non-profitable base meeting, Zoom meeting, in which there is no interest of Mrs. Tahir and Mr. Mike and Dr. Arshad and Dr. Zora. So we all are here just for the sake of humanity and for those quarantine women who are quarantined in such COVID prevalence and who are not performing their antenatal OPD regularly. So for the sake, and apart from it, our healthcare professionals, what are the actual protocols? Because in Pakistan we are following such protocols, but a message from UK and such doctors that are graduated from RCOG and working in NHS. So it's been a great honor for us and for Pakistan that you will inform us about the actual protocols and actual guidelines and what are the current situation, prevalence, epidemiology, and what are the screening tests that you will be informing us through this seminar. And thank you once again, all of you, for taking your time. And without wasting any time, I just move forward to introduce all of you. In our panel, there are four obs and gynecologists having more than around 20 years of experience, all of you. So starting from UK, United Kingdom, Dr. Amber Tahir. She's an MBBS AMC Dow RCOG physician from Ireland. She has completed as a DFF family diploma. And from RCOG, she's also an RCOG and CCSD obstetric gynecologist. She's basically a consultant gynecologist and a clinical lead in National Health Service England. Apart from it, she is an ex-chairman of UK Senior Academy Tutor University of Birmingham and expert witness of GMC. In line with her, we have Dr. Mike Cohn. She's an MD of RCOG, consultant gynecologist and a clinical lead. He's also a member of RCOG, British Medical Association, British Menopause Society, Medical Defense Union, and consultant in Bay Valley NHS Trust. So they are both from England, and from Pakistan we have Professor Dr. Ashad Chauhan. He is an MBBS, FRCOG, FCPS, double FCPS, and CEO of Craft IVF. Apart from OBS and gynae, specialty he serves as a specialty in the field of fertility, and he is the current chairman of Lahore chapter SOGP Society of OBS and Gynae Pakistan, and chairman of Society of Human Reproductive Health. He's a former Dean Faculty of Obs and Gynae CPSB, former professor of King Edward University, and HOD of Lady Blington Hospital. He's having a vast experience of 34 years. And last, we have Professor Dr. Zora Khanum, and she's an MBBS, MCPS, FCPS, APS, FCPS double gynecologist. Mainly, he's a health professional education. She has completed his diploma in advanced endoscopy from France and gynecological endoscopist from European Academy. The professor in current Fatma Jinnah Medical University. So thank you so much. Over to you. First, initially starting from Dr. Amber Tahir. Today her topic is prevalence, epidemiology of COVID, challenges, vertical transmission, probability and impact on pregnant women's health. So she'll be discussing about the UK epidemiology and prevalence of COVID-19 in pregnancy. Apart from it, she's also informing us about the symptomatic, is pregnant women are symptomatic or asymptomatic of COVID-19, and what are the chances of fetal anomalies, miscarriages, preterm delivery, and during pregnancy. What are the actual laboratory screenings and medication in pregnancy which are prescribed, which are guided to be given during pregnancy by RCOG or any other guidelines. So over to you, Dr. Ambatai.
Okay, I can't share my.
You can share it now. When I'll be putting it off, stop sharing. You can share it now.
Okay. Thank you very much, Dr. Zubair. So I'll just talk about a brief introduction about COVID-19 infection in pregnancy. COVID-19 pandemic, which has affected worldwide, which has affected the whole world and brought it in under lockdown, is caused by a new strain of a coronavirus. We know coronavirus family is not a new family. Coronaviruses, they cause upper respiratory infection. Mostly, usually they cause mild to moderate upper respiratory infections. This virus, which is a novel coronavirus, SARS-CoV-2, as it is named as, is a new strain of coronavirus, which was first identified in the Wuhan city of China in December 2019. We also are aware of two well-known upper respiratory infections caused by other coronaviruses. MERS-CoV, Middle East Respiratory Syndrome, and SARS, a well-known SARS, which is caused by coronavirus as well. So it has affected worldwide. In Europe, the two countries which were badly affected by COVID-19 infection and with a high death toll were Italy and Spain. And currently, UK has the second highest death toll in the world after United States of America. So Royal College of Obstetricians and Gynecologists has issued a new guidance and guiding us how to manage pregnant women with COVID-19 infection during pregnancy, during labor, and postnatally. Main priorities are, number one, reduction of transmission of COVID-19 to pregnant women, and secondly, provision of safe, personalized, and women-centered care to pregnant and postnatal women with suspected or confirmed COVID-19. On 20th of March 2020, the UK Obstetric Surveillance System, UCOS, launched a registry for all women admitted to UK hospitals with confirmed COVID-19 infection. And we know that there is an evidence of transmission from human to human transmission. Initially, it was transmitted from animal to human, but now we know that it is transferred one human can infect the other human. Virus has been isolated in respiratory secretions, in feces, and in fomites. And there are two main routes by which COVID-19 can be spread. Firstly, close contact with an infected person within 2 meters, where respiratory secretions can enter the eyes, mouth, or nose. And this increases the risk. The risk increases the longer the person is exposed to with an infected person who is shedding the virus. Indirectly, it is spread via touching of surface, object, or the hand of an infected person contaminated with the respiratory secretions and subsequently touching one's own mouth, eyes, or nose. Pregnant women do not appear more likely to contract the infection than the general population. And we know that in pregnancy itself, itself alters the body's immune system in response to viral infections overall, and generally it's more in pregnancy, which can occasionally cause more severe symptoms. And this will be the same for COVID-19. With regard to vertical transmission, which is a transmission from mother to baby, antenatally or intrapartum, there have been 2 reports published so far with an evidence of IgM for SARS-CoV-2 neonatal serum at birth. And since we know IgM does not cross the placenta, this would represent a neonatal immune response to the in utero infection. And the UCOS study reported 2.5% of babies had positive swabs within 12 hours of birth. This is very different from the previous evidence which we got from China, which indicated that amniotic fluid, cord blood, neonatal throat swabs, placental swabs, genital fluid, and breast milk samples from COVID-19 infected women and their babies have so far they were all tested negative. However, there are serious methodological limitations with this conclusion, and the proportion of pregnancies affected and significance to the neonates has yet to be determined. How COVID-19 infection affects the pregnant women. As we know, largely in general population, 80 to 85% people infected with COVID-19, they are either asymptomatic or have mild symptoms. So mostly women during pregnancy, they will experience only mild or moderate cold or flu-like symptoms. cough, fever, shortness of breath, headache, and anosmia, which is loss of sense of smell, are other relevant symptoms. More severe symptoms, fortunately, they are less frequent. Severe symptoms such as pneumonia and marked hypoxia are widely described with COVID-19 infection in high-risk groups. And these high-risk groups are women who are more than 35 years of age, who are immunosuppressed, and those who have long-term conditions such as diabetes, cancer, chronic lung disease, and also some minor ethnicities, which I'm going to talk about later. Now, UCOS study is the largest population-based cohort of pregnant women admitted to the hospital in UK with COVID-19 infections to date. About 427 pregnant women were admitted to UK hospitals with confirmed SARS-CoV-2 between 1st of March to the mid of April, and which represents about 4.9 admissions per 1,000 maternities. Out of these 427 pregnant women, about 9% of these women required level 3 critical care, and fortunately less than 1% received extracorporeal membrane oxygenation. Sadly, 5 women who were admitted to the hospitals with COVID-19 infection during pregnancy, they died. In the UCOS data, the median gestational age at hospital admission was 34 completed weeks. And mostly these women were hospitalized in the 3rd trimester of pregnancy or peripartum. 59% of the women who were admitted, they had cesarean births, and approximately half of these were because of maternal or fetal compromise. The remainder were for obstetric reasons, for example, poor progress in labor, previous cesarean birth, or maternal request. Out of these 59% of the cesarean births, 20% of these sections are performed in a general anesthetic, mainly because of severe COVID-19 symptoms or few because of urgency of birth. As I mentioned earlier, there are some high-risk groups, and if these women fell in these high-risk groups, they respond more severely to COVID-19 infection. And these groups include Black and Asian women or other ethnic minorities. Those with coexisting comorbidities like diabetes, chronic lung disease, I already mentioned, or those who are above 35 years of age or overweight and raised BMI. This suggests that women with these risk factors were disproportionately affected by hospital admissions instead of COVID-19. The association with Black, Asian, or minority ethnicities is particularly apparent and echoes previous findings. And the reason for this association is unclear. We do not know. It has been postulated that it is related to either socioeconomic or genetic factors or differences in response to the infection. We know that pregnancy is a known hypercoagulable state, and emerging evidence suggests that COVID-19 patients who are admitted to the hospital with this infection, they are also hypercoagulable. So these two factors, plus the fact of reduced mobility, either they are isolated in their homes or they are reduced mobility because of a hospital admission, is likely to increase the risk of venous thromboembolism. So the guideline actually advises to use low molecular weight heparin in these ladies if they are hospitalized. And also they will be discharged home with a prescription of low molecular weight heparin for 10 days after delivery in order to reduce the risk of venous thromboembolism. As regards to the effects of this infection on the fetus, there is currently no data suggesting an increased risk of miscarriage or early pregnancy loss in relation to COVID-19 infection. And there is no evidence currently that this virus is teratogenic, but it is a new strain. We need to really understand that. And as I've already mentioned, that recent evidence is that there is a probability that this virus can be vertically transmitted, although proportion of pregnancies affected and the significance to the neonate has yet to be determined. There are case reports of preterm birth in women with COVID-19, but it is unclear whether it was iatrogenic because of the medical intervention due to COVID-19 symptoms, or whether some were spontaneous. Iatrogenic birth was predominantly for maternal indications related to the viral infection, although there was evidence of fetal compromise and pre-labor, preterm rupture of membrane was noted in at least one report. So I'll finish here. Thank you very much.
Thank you.
Over to you, Dr. Zubair.
You're muted.
Okay. Thank you so much, Mrs. Taher. Over to you, Dr. Mike Kwan. So your presentation, you can share your presentation.
I'll just share my screen first of all.
Okay.
There we go. Good. So thank you, everyone. Can you all hear me? Yeah.
Yes.
Yeah.
Thank you very much. So I'm going to be talking about the change in maternity and gynecological care, mainly maternity, during this time. So with the antenatal care, we considered this and looked at guidance from the RCOG and other local units. And the general feeling is we should continue with normal antenatal care, but try to reduce the number of contacts by using phone and video. And I'll show you the regime that we stuck with. Obviously in the UK, we have our midwife system as well. And so the midwives do quite a lot of the low risk contacts, or contacts in low risk women. If a woman has a proven or suspected COVID, then the idea is to further contact for 2 weeks unless it's urgent. So rather than booking them at 12 weeks, booking them at 14 or 15 weeks, they had a scan for 32 weeks, we might put that off to 34 weeks, unless we were particularly concerned about that baby and felt it should be scanned at 32 weeks. Any contact with a patient should be using some form of PPE, which in the UK is basically a face mask, but not a FFP one, so not a exclusion one, an apron and some form of eye protection. Now, if you're on 2 meters or more away, then we're not really using much at all, apart from the usual frequent hand washing. We also changed our policy, so rather than having GTTs, where the patient's got to come for an hour and hang around, or come for 2 hours, we're now doing it as an HbA1c and a random blood sugar test at the 25 weeks or for patients in a risk group, or 16 weeks if they've had previous gestational diabetes. And so far that seems to be picking up the patients who need to be picked up. So that's the sort of the main antenatal changes we've made. So this is the regime that we came up with, and really matches what most other people in the UK are doing. So trying to have a booking done by the midwife in the home or in the community clinic, face to face, that's what F2F stands for, and do all the blood tests then. Previously we used to have 2 visits, each for about half an hour. And so now we're doing it all in one go and taking about an hour and a half. They would then come to the hospital and have their dating and scan, and if they wanted to have screening for neural tube defects, that would be done at that stage. And then the midwife would review the results and check their well-being, but that would be with a video call or telephone call, so not having to actually see the patient face to face. When they come to the hospital for their anomaly scan at 20 weeks, then, which obviously has to be face to face, the midwife in the clinic would also take their blood pressure to save another community midwife visit. We're trying to reduce the number of contacts. We used to do, we planned to do normally a visit at 25 weeks. That's now been dropped, and the next contact will be at 28 weeks when the 28-week bloods are done, and if they need rhesus T prophylaxis, that would also be offered. Then the next contact will be 32 weeks, 36 weeks, 38 weeks by video again, and then 40 to 41 weeks. Now, also if these patients are high risk and they're perhaps coming to a consultant-led clinic, then we'd have to adapt those contacts to fit in with what we wanted, but the midwife ones would then be dropped if they're in a similar sort of time to save double contacting. So it's trying to make the whole thing as efficient and sensible as possible, and also reduce the number of contacts, A, for who's used to the risk of transmission, but also the patient coming into hospital and putting herself at risk of picking it up in the corridors, etc. We're trying to reduce all those contacts in a stay safe, stay at home type message that our government was pushing over the last 2 months. So I said for higher risk women, we would book extra appointments as required, but avoid duplication. Our current scanning regime would be a booking scan of about 10 weeks or so, which would include the NT measurement if the patient wished, and then an anomaly scan at 20 weeks or so, then no further scans unless clinically indicated. But if they were clinically indicated, the idea is we'll keep the same thing. Early on, there was concern that we may not have enough staff to run the whole service. This was nationwide rather than particularly just an R trust. And so the RCOG came up, so if you've got to limit your scanning service, then the anomaly scan is the most important one to keep. And probably after that would then be your growth scans on the high-risk patients, the previous SGAs and growth restricted women, preeclamptics, etc. So probably the booking scan will be the first one to be dropped. And we do quite a lot of routine scans on people who have high BMI because we can't measure the baby. That would be something we would be more likely to say, let's not do that if you really were struggling with scanning. But at the moment, we managed to keep our service going throughout. So how do we prepare the hospital for patients coming in? This creates a lot of concern, extra work when the whole thing kicked off. And we had quite a lot of input from our infection control team, who number about 4 or 5 nurses and a consultant microbiologist. We designated a delivery room for looking after patients who either have got COVID-19 or may have COVID-19. So if they had symptoms or had been in contact with somebody in the last 14 days who had it. And this is one of our delivery suite rooms. It's on the first one you come into, you enter the delivery suite. And the main thing was there was a space for donning and doffing. This is putting on your protective equipment and taking it off again. And our government pushed quite hard on ways of doing this and how to do it adequately and trying to reduce the risk of contamination. And it had to be space for that, and hand washing space and hand gelling space, and rubbish bins to put the infected or potentially infected kit into. So we had to have a space that was near that. We also had to have a similar space for near our obstetric theatre so that you could don and doff it adequately there before you actually went into theatre. And so we actually had to take over our anaesthetic room for that, so that anaesthetic room is purely for donning and doffing and keeping equipment to be passed through the doors into theatre, with the idea that all these rooms that are set up for COVID patients have the least amount of equipment in them possible, so that when the patient leaves, there's the least amount of cleaning to be done. So we really sort of prepared the areas quite carefully. This had quite a lot of effect on our capacity in labour ward because it took out one routine obstetric delivery room, and also our anaesthetic room was actually our second theatre, so we took out that capacity, so we had to cope with that. The other thing is then to get your staff to practice donning and doffing, because it's quite a palaver to do it well and to do it effectively and reduce the risk of cross-contamination. So everybody had to be trained and signed off they've been trained, and there are various videos that we had available to look at as well. And I think we've now done quite a few practice runs, and everybody's confident in doing that. We also had a regime for transferring the patient to theatre, because if you have got a positive COVID patient, they're going to be taken down the corridor into the theatre areas. We had to make sure that we had ways of doing that without reduced risk of contaminating other areas and other patients. Excuse me. But the whole thing does slow down a category 1, an emergency zone section. As staff members, we've got to be aware of that and make sure that we act promptly when needed. And also the patients need to be given some realisation that it's rather than a sort of 15-minute call to delivery, it may take a bit longer. So we also then wanted to prepare the patients of this COVID would be, if they were affected by COVID or potentially had COVID, would be changing things differently. So in fact, all our patients coming in are only allowed one birth partner with them. They can't be the mother and the grandmother and the husband or partner all there. It's just one birth partner, and really it should be someone. We said it should be somebody who's normally in the household with them. We didn't want a mother coming in from another household and increasing the risk of having 2 contaminated people coming in. Also, no visitors whatsoever. The whole trust has put in the idea, or the whole hospital has put in, there's no visiting on the wards, and so this would be the same for our postnatal mothers as well, or our antenatal mothers hanging around. No visitors. In fact, we don't even allow the birth partner to cross to the maternity ward until the woman's in labour. And generally getting the patients home as soon as possible. So the sort of breastfeeding support, the other things we might have offered in the postnatal ward isn't happening. They get it more in the community. We also encourage patients who thought they may have COVID or were at risk of it to ring before they come in. We didn't want them just strolling up the hospital corridors and to find their way up to labour ward. So when they ring, we then tell them to ring when they're approaching the hospital, and then the midwife goes downstairs to meet them, put a mask on them, and bring them up through the safe corridors until they get into the labour ward and our specially designated room. We're trying to reduce this cross-contamination as these patients come into hospital. And generally, all patients have complied with this really well. People have, as you're aware, probably staying away from hospitals rather than coming in too often. We do say anyone who's got COVID is treated as a high-risk patient, so we would then wish to monitor them more carefully in labour. And in the UK, obviously, we use electronic fetal monitoring to do that. And so we've encouraged people not to have a home birth or not to have a low-risk type water birth if they are COVID positive. And if they do deliver successfully without any problems, then we then discharge them home straight from the delivery room rather than going back to the postnatal ward. So that's things we were telling the patients before they're due to come in, what we're going to do. For the birth, we actually now swab all our patients. When we first introduced this, when we first introduced our COVID measures, we didn't have enough swabbing. But now the hospital in the country does have enough swabbing. So now any patient coming into hospital overnight, which therefore like to be a maternity, a delivery, plus even the antenatals or the postnatal readmissions, they get a swab on admission. We try to keep them isolated in their own side ward until the result of that swab is known. I've said here it takes 4 to 16 hour turnaround time. I've now been assured by microbiologists they can do it the turnaround in 5 hours because they're now working overnight doing it as well. So it does reduce the locking of side rooms on our postnatal wards. But even so, it does take a bit of sort of a regime to make sure that all happens promptly. The national guidance is there's no need to change the timing of birth, the mode of delivery, or the analgesic routes, or analgesia on offer. So the risk of COVID doesn't seem to increase that unless they're particularly unwell, and we'll talk about that in a minute. In the UK, we say as a GA is a aerosol generating procedure, full PPE, that's with the fit mask, should be worn, and the full screen visors and so forth. So even though a lot of our elective sections are done under spinal anaesthetic without without the risk of aerosol generating procedures, the moment our regime is any section, any operation done in theatres is done in full PPE, which I don't know how many of you worn it, but it really is quite cumbersome, reduces risk, makes communication much more difficult, and really gets quite hot after a while. So, and it does to slow the whole process down, but that's our current guidance, wear full PPE in those situations. This is a chart I put up for what the obstetric anaesthetists developed, the OAA, Obstetric Anaesthetist Association. So no evidence that epidural spinal analgesia is contraindicated, so basically carrying as normal. No contraindications, or just use the usual contraindications of neuroaxial block, which obviously would be some spinal problems or low platelets, etc. Generally recommended to have epidural analgesia if they are COVID positive. So if they did need a spinal section, there's a greater chance of being able to do it under an epidural rather than a general anaesthetic. There was this slight risk of thrombocytopenia in COVID patients, Wuhan advised us. So every patient should have a platelet count prior to putting an epidural in. And there was a lot of discussion early on whether Entonox was an aerosol generating procedure and therefore increased the risk of transmission. And the current guidance is of using a microbiological filter. That's not the case. So patients can be offered Entonox as per usual. So we also then declared the guidelines of what to do if patients do actually have COVID and have significant respiratory compromise. We've, touch wood, never had this in Hereford in our trust, so I've cribbed these ideas from the Birmingham trusts, where it's a bigger setup and it's our tertiary centre. So they came up with these. So we're talking about a patient who's got their oxygen saturations are less than 94% on air, or they're requiring their oxygen to keep their saturations up. They've got a respiratory rate of more than 30, or they've got evidence of pneumonitis on an X-ray. The most important thing in this situation, if you do have a patient admitted, that is to have an MDT, and between the obstetrician, the midwife, the anaesthetist, the paediatricians, and I suppose that should have put down the medical physician as well, looking after the patient, and really decide the best management. If they're not ventilated and they're more than 34 weeks, it's probably sensible to consider delivery sooner rather than later to help the patient to ventilate, reduce that diaphragmatic pressure, and make it easier for them to breathe in that situation. If they're 28 to just under 34 weeks, then the recommendation is to consider steroids to help lung maturity of the fetus, and then transfer to a unit which has a neonatal unit, and then consider delivery once you've got the steroids on board, and probably using magnesium sulfate as well if they're less than 30 weeks to improve brain protection. 23 to 27 weeks, we're on the cusp of viability, and obviously in Pakistan it may well be a different cutoff. Consider steroids, but not deliver unless the condition worsens. And less than 23 weeks, as aortocaval compression was less of an issue, the patient was not too ill, i.e. not requiring ventilation, sit tight and see what happens. If they're a ventilated patient, then an oxygenation is being maintained, so hopefully just gone onto it and we're planning to get it off fairly shortly afterwards, continue with the pregnancy unless they're more than 34 weeks. But aim to keep the pH above 7.3 if they don't become acidotic, because that's not good for the fetus. Most COVID patients should be nurse prone. This is now non-pregnant ones because it helps ventilation. But obviously a pregnant patient, that's difficult, or nigh well impossible if they've got a big bump, and therefore using a left lateral tilt with more than 20 weeks. But if the patient requires ongoing ventilation, then there's got to be in the repeat MDT discussion, decide whether delivery, no matter what the gestation, is required. And obviously there may be a termination of pregnancy if it's under 24 weeks gestation, with the idea that the fetus would have little chance or no chance of survival. So far, touch wood, we're not be in that situation, but I know we've had colleagues in the West Midlands who have. Postnatally, as Amber's already said, you should prescribe low molecular weight heparin for 10 days, and obviously longer or a higher dose if they've got other risk factors. Breastfeeding should be encouraged, and the mother should be told that they should be sensible with hand washing before touching the baby, the breast pump or bottles. Try to avoid coughing and sneezing on the baby. Consider wearing a face mask, and that sort of the face mask story rumbles on as whether it's useful or not in reducing the risk of transmission. If a mother is expressing breast milk in hospital, then she should have her own dedicated breast pump rather than the risk of sharing and not decontaminating properly. And obviously, breast pump cleaning should be used as per recommendation. And the other thing that we've encouraged since the COVID thing is postpartum contraception, because access to primary care has been reduced during our time. And so some patients may be slow to access either the long-acting contraceptive methods or the progesterone pill or whatever it is. So the idea is we can discharge them home from hospital or even fit a coil or a Mirena in immediately postpartum. So that's an option there. So I think that's most of the things that we've introduced locally and in the region to try to make sure we look after patients as smoothly as possible. I'm happy to take questions if that's appropriate.
Mike, can I ask you a question? Because the concern is about the general anesthesia.
Yeah.
A patient who has got lung infiltration, how do you take that case at that situation? Because
well, so far we've not had to, but I think they would be looked after by a theatre team with everybody fully prepped up in their PPEs, that's face mask or respirator if they can't fit a face mask, screening, gowns which are waterproof gowns and gloves, and even the people who aren't actually scrubbing into the case are wearing gowns and all the full works. Try to keep the number in theatre down to a minimum, which is therefore probably at the time of intubation, 2 or 3 people, either the ODP, assisting anaesthetist, and the other people standing well back from the patient. And once the intubation's performed, once they've got a good seal, then the AGP risk disappears apart from any droplets in the. So if you've got time, there's not an emergency end section, you probably wait a few minutes before you get everybody back into theatre to carry on and deliver the baby. our anaesthetists obviously intubating patients in ITU in that situation, so it's a similar risk to those. Is that the question you're asking?
Yeah, and one more question. Like you said, the analgesia would stay the same in these patients as far as the pain relief and labor is concerned. Would you not be bothered about the hypercoagulability associated with it?
Well, I did say that, well, afterwards they're going to get their low molecular weight heparin. I suppose we'll try to do mobile epidurals, which means they do have a degree of mobility in their legs, variable, because they have a pump so they can adjust the dose themselves. If anything, the risk at the time of putting in the epidural is the risk of them having DIC or having a low platelet count. So let's say at the moment the current thought is that whilst they're in labour they can have their epidural and keep as mobile as possible, wear their TED stockings, and then postpartum get them on the heparin.
Okay, I have one question. For a patient who is planned for the elective surgery, like a patient who has previous 3 cesarean section, and she comes to us 37 weeks plus gestation, and she is COVID positive. Either we have to wait for certain time to get her second test done if she gets negative, or it is the indication for cesarean section at a due time.
I would think so, yes. I think if you say she was 37 weeks, I'd certainly try to put it off to 39 weeks unless there's a particular indication for going sooner. I suppose if she presented at 39 weeks with that, we probably would say, well, look, we'll swab you now, we'll swab you if you come in labour, and then we'll get on with the section when you come in labour. Try to put it off while she was officially COVID positive.
Okay. And what is your routine practice for the baby, for the neonate, after the delivery, the baby is kept with the mother?
Yes, kept with mother, yeah. As Amber said, there is a greater risk of them requiring admission because that's more due to prematurity than...
Okay, thank you.
And our neonate, although the risk of an aerosol generating procedure from neonatal resuscitation seems to be very low, our current policy is they will wear full PPE before they start intubating or before they start doing breaths, inflation breaths, because it's the risk is low.
Can I just add to Dr. Zora's question? For elective, you're talking about elective section at 37 weeks.
Elective section. At 37 plus, it's 38 weeks or 38 weeks for 3 days. Patient comes, she's a COVID positive. So what will be the appropriate time for delivery? Either we will wait for her second test to get negative, or either we have to just plan the elective surgery in due time.
So normally we leave them for 7 days, isn't it? If they're COVID positive, we leave them for 7 days.
Okay, same we are doing here. Oh, thank you very much, because same way to practice the same practice here.
Now the risk is obviously she labours before you get there. See, this is assuming the baby's in good condition. You're not unduly concerned about fetal well-being. But if it's purely elective, then I would say let's not do it now. Let's try to get you being non-COVID positive before we do it. With the idea being, if you think you're in labour, come in sooner rather than later, and we'll have to do it under full ultra cautious PPE.
Yeah.
Well, actually, sorry, I did see on my title there's also gynecology as well. I don't know if we've sort of reduced our gynecology output quite significantly with us doing cancer patients at the moment. We've also had quite a lot of discussion in the college about what to do with laparoscopic procedures. I see you're a laparoscopic endoscopist, because there's this meant to be a slight theoretical risk of AGP during laparoscopy with things being vented into the air.
Currently, we are just doing the more focus on the obstetrics, not on the elective gynecological surgeries.
We're doing the same thing, really.
Oh, yeah, we're doing the same thing. But what Mike is saying is that we're trying to avoid laparoscopic surgery. So any laparoscopies, we're converting them into open procedures in order to.
We're doing like topics laparoscopically, but taking care to vent before we take out the sample and things like that. And vent into a suction bottle rather than just venting into the open air.
Yeah.
There's quite a good college guidance, or the BSGE guidance on the college website on that.
Okay. One more question. Your routine practice in obstetrical unit. There is a triage for screening the suspects from the routine obstetrical patients?
Say it again, sorry?
There is a triage for screening.
Yeah, well, anybody who comes in labour who's likely to stay in hospital overnight, they get swabbed now. Anybody. Now, all our patients get swabbed, not just the query ones now. Originally, it was just the query ones. We've now done it routinely to every patient. We've got this. Well, the hospital's got the capacity, and the UK tried to ramp up its capacity to at least 100,000 tests, which they struggle to do. But our trust is managing to do that, so we can swab anybody who comes in hospital. Whether the test is that reliable, because there's certainly been cases reported where the throat swab is negative, but when they do a lung aspirate, it's positive. So I think you've still got to treat a negative swab with. Still got to treat the patient with caution, but it gives you a bit more information as to what's going on.
I was wondering a question. Have you 14-week pregnancy or 18-week pregnant woman? I guess in second trimester is reported till yet in UK, or is there any chances of preterm delivery or congenital anomalies in such baby, or chances of miscarriages in such weak pregnant women? Positive COVID woman.
I think if they have a COVID positive, especially with a high fever, they run the risk of miscarriages. I'm not aware, I think my evidence is there's no evidence that it actually increased the risk of teratogenicity. So I think it's either it's a bit like a high fever in any early pregnancy. There's the ones that risk of miscarriage.
Yeah, it's like any sepsis, isn't it? It's any sepsis. If the patient is really unwell, she's going to miscarry because of that. But as per to COVID, specifically talking about COVID-19, there is no evidence that it is a teratogenic virus and it causes fetal anomalies or miscarriage or increased risk of preterm delivery even, because the cases reported for preterm with preterm births were, we don't know whether they were iatrogenic, as I mentioned, because of medical intervention because of the COVID-19 symptoms, or some of them went into spontaneous preterm labor.
Okay. So
the risk of fetal anomalies is minimal. I mean, we don't know. There is no evidence.
Okay. So moving forward to Professor Dr. Arshad Chauhan. Sir, your valuable topic was you will inform us about the prevalence and epidemiology in Pakistan, and what we have discussed about the vertical transmission in pregnant women. You will inform us about the impact in pregnant women in Pakistan and breastfeeding among COVID-19 patients in Pakistan. What are the guidelines, sir? Over to you.
First of all, I would like to appreciate Dr. Amber and Mike for a beautiful presentation and covering the whole subject thoroughly. We have learned a lot of things out of it. But here in Pakistan, we differ significantly from the situation in the UK. Though we are all UK, we are all FRCOG and we have followed the Royal College guidelines. The way it is being practiced in United Kingdom, we are trying to follow it here as well. But we differ in various aspects from the prevalence point of view and epidemiology point of view. So I'll give you an account of situation with Pakistan. The prevalence is directly related to the testing capacity. And in Pakistan, if we take it today, it's 13,700 tests are being done per day. And so far we have done 344,000 tests in total, and 37,000 cases have been confirmed. In last 24 hours, we had 33 deaths. And so far, since the pandemic has set in, the total of deaths in Pakistan is 800, which means the burden of the disease is not that great as it is in Europe or as it is in United Kingdom or US. We have to focus on things because when we are testing people, many people are turning out to be positive, but the percentage of symptomatic patients is significantly low. Patients needing admission is low, and patients going on assistance of oxygen or ventilation is not comparable with the United Kingdom. Hence, we do have a burden of COVID positive patients in pregnancy, but it is not to that level to which you might be seeing in the United Kingdom. The first case was diagnosed in Pakistan on 26th of February. And since then, what we have seen and watched is that patient, there is different way of presentation in Pakistan. Many of the patients are COVID negative, yet they have chest, which is typical of COVID, on CT scan, CT, or on even X-ray. We see the chest is grossly infiltration and pneumonia, but patient is COVID negative. And we are seeing the same in our pregnant women. At the same time, the behavior is different. The patients do not present when they have early part of symptoms. They come when they become breathless, and some of them reach hospital and they die within 24 hours without getting a lot of opportunity to take care of them or without going into details. As far as the hospital burden is concerned or the pattern of working is concerned in the country, the government has actually selected the hospital for COVID positive pregnant women. And Professor Zora is working in one of the hospitals which is taken as the focal hospital, where all the COVID positive patients are taken up and they are they are admitted for times when they have symptoms, and they treated as far as the problem gets over. The main the main thing which I want to talk about is that we have different challenges in Pakistan. The first challenge is the challenge of population. We are dealing with a much bigger population as compared to the European countries. If we put them to the lockdown, it is very difficult to keep this size of people under lockdown. And even when we have complete lockdown, still we will have people on the road which would be comparable with any of the European countries. Hence, the spread cannot be stopped. But as far as obstetrics is concerned, the way Dr. Zubair has asked me that I should talk about the relevant things is that we have a joint family system. We have multiple number of people living in the small houses, and social distancing is a serious issue with us. And in that case, those who are pregnant, they get infected, and there is a probability of them to going to the serious situation. And then when it comes to the breastfeeding, the baby is not only looked after by the mother alone. It is the whole family which is involved in taking care of the baby. And we really have to work hard on them to make them understand how to isolate that baby from the family. The way it has been, Mike has explained that the breastfeeding, we should keep separate things, we should sanitize, we should make the bottles in a different way. But we have to actually settle with the family members to save the baby from all the family, which is a risk to that baby as far as social distancing is concerned. As far as management is concerned, we are in hospitals, we are following basically for the low risk pregnancies, we are following 4-week antenatal care model. That we see them because we see in the antenatal clinics up to 200 to 250 patients per clinic. And if we call them all to the hospital, social distancing becomes impossible. And what we are practicing here is that we see them once for the booking in the first trimester, then we see them at 18 weeks of gestation for the anomaly scan, then 28 weeks for growth, and subsequently at 36 weeks. I'm talking about the normal population. And rest of the time they are seen by the regional family physicians in their area. That way we are maintaining the social distancing and we are reducing the hospital burden for low risk antenatal pregnant women so that they do not get crowded. The biggest problem in Pakistan is the risk for the health workers, because PPE are not available to that extent and with that quality that we can cover all doctors. And if you take any community or any section of the community in Pakistan, the healthcare providers are at highest risk of getting infected. And we have lost so far 4 doctors, and 2 of our professors of gynecology have gone through the COVID, one had minimal symptoms, but the other one had a very serious situation that she went into critical situation from where she has returned in the past 2-3 days. And then when Mike was saying that the delivery pattern is according to the ability of the neonatal care services to cater for the premature babies, unfortunately, we cannot expect the survival of that level at 28 weeks. So we generally start the survival rate from 34 weeks onwards. If we deliver babies before that time, the survival is not that great, and it discourages us because we lose the babies if we deliver them early. As Dr. Zora was asking the question, that we can give them steroids, but if we deliver the babies before 34 weeks, majority of the neonatal services will not be able to cater for the premature babies. Then I think most of the standard things have been covered by Dr. Amber about the vertical transmission or the other risk factors, the other issues related to hypercoagulability, and generally the message is that pregnancy does not increase the probability of getting infected with COVID, but it does increase the probability of severity of symptoms, particularly when we reach to the third stage of labor, rather to the third trimester of pregnancy. So if I have to give a take-home message to the audience, I would say that social distancing does work, and I would tell them to stay home, stay safe, and keep social distancing. To share life with the dear ones, you need to be alive. If meeting them can endanger your life, then it's better to hold back till the time is right to share happy moments for a longer time. Thank you very much.
Great, sir. Great words by you. So, in last, without wasting in time, we are very short of time, and so over to Professor Dr. Zora Khanum. So her topic is precautions for healthcare professionals and their experience for private and practice. So precautions may include the setups of midwives and specialists. So, madam, over to you. What are the precautions and what are the take-home message?
Okay. Thank you very much, Dr. Zubair. I am really grateful to Dr. Amber and Dr. Mike and Dr. Professor Arshad Chauhan for sharing their knowledge. And I will just continue what the Professor Arshad Chauhan has said, and he has talked in very detail about the local situation in Pakistan. I feel so the main challenge here in obstetric unit is that most of the patients in tertiary care hospital, in public sector hospitals, they are unbooked patients. And they are with a low hemoglobin, they are with anemic, they are with the comorbidities. So that what I was talking and asking to the mic, that how they are managing, it's important for us to screen our patients so that there are the number of patients where they are the suspects COVID and we deal them suspect COVID. We send their investigation, the PCR is done and they turns to be negative. But in a specific area, so that we are just dealing our patients in three areas currently here. One is the COVID confirmed, the other is the suspect, and the third one is the routine healthy pregnant patients. So that coming to the point, for the healthcare workers, as the Professor Chauhan has said, that they are really at threat because of the heavy workload and because of the comorbidities and the increased number of the suspect patients. I'm not sure about after 2 weeks and after 4 weeks what will happen here. One very important, I want to share that here, because the number of patients not like in Europe and the other like in other countries, so that sometimes the people, they are not taking it too much serious about from prevention point of view. But the healthcare workers, they are taking it serious. And just from prevention point of view, I think so, it's not only the doctors. It also includes the nurses, the paramedics, the laboratory staff, the cleaners of the hospital, and the APAs in our local setup, IR in our local setups, and also even the ambulance driver who is shifting the patient. The care and prevention for all them is very much important. It is a very special situation because the healthcare workers, they are at the front line for COVID-19 outbreak, and they are more exposed to hazards, and these hazards are infectious. And no doubt, other than infectious, because of the long exposure of PPs, because of the heavy workload in specific areas, and their doctors, the paramedical staff, they are really working under stress, because at one side the patient is not aware of the situation, but on the other side the healthcare workers are aware of the situation and they are very careful. So that this all is leading to the psychological stress also. First of all, before going to the prevention from healthcare professionals point of view, I just want to focus a point that every healthcare professional, including doctor, nurses, and every staff member, should also be aware of the local protocols and SOPs of a specific organization in specific situation. Like if I have defined, we are working in 3 areas. One is the normal routine pregnant ladies, the other is the suspect, and other is the confirmed diagnosed COVID-19 patient. So that every care worker who is working there should be aware of the specific SOPs, the working protocols in the specific situation. So I feel so it's the responsibility of our organization to provide the PPEs, and depending upon the situation where they are working, it's important that they should provide the proper trainings to their healthcare workers according to their job specification and area of working. And no doubt, there should be the refresher courses. It's not only the one time, because it's an evolving situation, and they should be updated, and there should be the repetition of the trainings for all these healthcare workers. And all healthcare workers, they should know how to go for self-assessment. That means they should look after themselves, and how they should check their temperature, how they should be more particular about the symptoms, and they should know the chain of command and the chain of communication if there is some problem regarding the local situation, the workload, the psychological stress of the doctor, or if any healthcare worker is not feeling well and is feeling that the person should be screened, and there should be a very clear strategy and SOPs of the organization to screen when and how to screen their healthcare workers. So I think so it is relating to the organization for the prevention of spread among the healthcare workers. And now I am coming to the roles and responsibilities of the healthcare workers themselves. Number one, they should keep them updated from the different sources like WHO guidelines, RCOG guidelines, NHS guidelines, and even the local society guidelines of the country about the prevention and the treating protocol about the COVID patients in a specific situation. And then there should be the sound knowledge about the procedure, like Dr. Amber and Mike have shared with us, like how to go for the antenatal visits, how frequently should be done, in which situation the patient should be attended by the teleclinics, when they should be called, when the specific investigation, how they should be tailored. And the most important, if there is some problem to the patient, then where they should be referred in the proper safe setups. Now coming to the next point, that's important from the patient point of view, that in the hospital, the healthcare workers should know that what are the protocols in different areas, like in outpatient departments. In outpatient department, what kind of protective equipment is required? Either if a patient is like, it's a busy outpatient department, if some patient is symptomatic, then how the healthcare professional has to refer this patient to the different specified area. Either the patient is in mass, either the healthcare workers, they are taking the proper care of themselves in a screening area. Similarly, they should follow the specific protocols for the indoor patients. Indoor patients who are healthy, pregnant ladies, either in the maternity rooms, they are in the labor rooms or in operation theater, or what specific care they have to take when there are the suspects COVID patients, or what the specific measures and the specific PPEs they have to take care when they are working in the confirmed COVID areas. Similarly, I feel so it's the responsibility of the organization and every healthcare worker to look after the second or the assisting healthcare worker. Like if I'm a doctor on duty, it's my responsibility. I feel so I should take care about the staff nurse working with me. Staff nurse should look after or either should check to the other workers, even the cleaners. Similarly, the staff who is transferring the patient from one area to the other area, especially in the wheelchair, couch, or in the ambulance, so that it's the responsibility of the organization to provide the specific updated SOPs and protocols for the care of health workers starting from every senior level, including the administration, senior consultants, doctors on duty residents, staff nurses, lab staff, cleaners, as well as the persons who are going for the transfer of the patient. I think so these are the just, I have briefed in because of the time I have briefed in. And the take home message is that prevention is better and we have to prevent not ourselves, also to the persons who are in our surroundings. Thank you very much.
So thank you all of you. Great message by both of doctors of Pakistan. Dr. Mike, what is the take-home message from your side?
I think the take-home message is, well, first of all, stay safe yourself, but also then have systems in place, stick to the systems, talk to each other. We have regular meetings, well, originally they were daily, but now 3 times a week. So everybody's fully up to speed. So just keep everybody on board and keep educating, keep on reminding people to get the system working correctly.
Okay, thank you. So, Mrs. Tahir, what is the take-home message from your side?
Yeah, the take-home message from me is the same. Stay safe and follow all the government instructions. Keep the distance, use the safety measures. Try to stay at home as much as you can, and only go out for your, very, very important urgent needs. Unnecessary roaming around or visiting people and visiting relatives shouldn't be the norm, and it should be discouraged. So just stay safe and look after yourself and look after others.
Okay. So thank you all of you. On behalf of Genix Pharma, I really appreciate your efforts that you have put in, especially the presentation which is put on by Mrs. Tahir and Dr. Mai. And apart from it, what a great knowledge discussed by Professor Dr. Arshad Chauhan. As always, sir, thank you so much. And apart from it, Dr. Zora, really I appreciate your effort on such you are in continue communication with me regarding the presentations and modus operandi of this program. So on behalf of Genix Pharma, I again thank you, all of you, and especially the Craft IB. Mr. Rashid Chauhan is the CEO of this Craft IVF. So in collaboration with Craft, I really thank you so much on behalf of the Genix Pharma, sir. And apart from especially Mrs. Tahir, really a great effort put by you, and with no personal interest in it, with no interest of any personal interest of Dr. Mike Khan. So a special thanks to APPS, Association of Physician, Pakistan Physician and Surgeon UK, and Al-Amal Medical College UK alumni. So these all are the collaboration partners of ours. So inshallah, and we have faith on God. So from this pandemic, we'll all together, we'll all health professionals will take it to the endemic, really. So anyone want to add? I'll say it.
No, I would like to thank all of you. I would like to thank Mike. He's given so much of his time and very nice presentation. Professor Chauhan very nicely presented the situation in Pakistan, and Professor Zora. So really, it was a good experience and good knowledgeable experience for me. Thank you.
Lovely talking to you all. And we learned a lot from the UK perspective. surely that is we are far behind in that line. The number of patients is low, and the facilities, obviously we have constraints with the population we have. But surely the guidelines which UK is putting up, we are following it, and you people are a great help. Thank you very much for sharing the experience.
Thank you very much all for sharing the knowledge, and thank you, Dr. Zubair.
We'll be in touch, inshallah.
Yes, Mr. Mike, you want to say thank you so much. So
I do. I just want to thank you. It's been very interesting. Yeah.
Thank you so much. On behalf of Genix Pharma, okay, take care. Allah Hafiz. Thank you so much. Goodbye.
Bye.
Pleasure. Thank you. Bye-bye. Both.
Bye-bye.